don't worry, because it's really difficult to pronounce my surname, even for me. But thank you very much for the kind invitation to Felix and the other colleagues responsible for inviting to me. The problem is when I read your invitation really fast. I read close of doctors, and I thought Felix for sure wants me to talk about the preterm. No, the complete title of the talk is preterm to adult, and I have to read all the life of the patient this morning in the hotel. Okay, for my opinion, there are three different periods of time to pay attention in order to of the percutaneous closure of ductus. Preterm is the most exciting. There is several articles in the last year. It's completely in fashion. It's really exciting, and perhaps this subject is going to take the vast majority of my talk. But there are other period of time. It's the 3 up to 8 kilos, and we are faced this kind of patient with calm, with safety, and in a relaxed way. And in my opinion, if you are working with autoexpandable devices, this is an average of age really risky. And adults, only some comments on technical comments that we have been learning from my adult colleagues, because it's not the same to close a small vessel in a bigger patients. It's not this context. What happened with the patients, with the preterm patients lost less than 2 kilos? Okay, we have been looking for to offer the percutaneous approach to the preterm, trying to avoid the complication of the surgery. But the surgeons have been increasing the skill, and they are doing minimal incision, subaxillary, but despite this, they are creating some contusion, some trauma over the leg, and even pneumothorax, and for sure, I have the conviction that they are altering the mechanism of the ventilatory system of the patient, and this fact could delay the extubation of the very small patient. Okay. We have the possibility to offer the percutaneous closure because we have small devices just now, and we are going to share with you our experience. This is our experience. It's 27 patients. This is the average of weight. The minimum weight is 1 kilo. I don't know. I don't have idea what we established this limit. This is a circular figure, I don't know, but 1 kilo was the limit. This is the indications, and the narrowest point by echo should be less than 3 millimeters. This is 27, as I said. We are reaching just now 40, I suppose, and the mean weight was 1,200 grams. All of them have ventilatory or hemodynamic repercussion. All the procedure was done at the CALAB under general anesthesia, and all the procedure was done also with the 82 additional sites. Okay, all 100% was C or E type, is tubular site, or with a slight restriction in the pulmonary side. And in the first 4 patients, we obtained artery access with a microcatheter or 2.7 inserted directly in the artery without seat or introductor in order to check the result in the aortic arc by Hanley injection. Okay, but the rest of the patients, we did all the things from the right side, and only with the recirculation phase, if you wait, you obtain a nice and quite good image of the aortic arch. And despite this, we check by echo before releasing the devices. It's really crucial, this point. Is in all the patients, we obtain a peripheral access on the feet, and with a tiny injection on 1 cc of contrast, and afterwards taking the image like a reference, it's really easy to obtain the femoral venous access. It's not easy in all the cases, and it's really helpful, and I recommend deeply. Okay, we are doing also for the right side. We are going with a guide catheter of 4 French. For sure you are familiar with the procedure. We deploy it because it's really soft in understanding aorta, the left ocular disc. Afterwards, we try to accommodate without touching the left surface of the ductus, and afterwards we check with an angio, with recirculation, and check also by echo before releasing. This is the clue. Okay, there are there were two embolizations, and we were so threatening about the situation. You can imagine this kind of devices embolize into the pulmonary lung, impossible to retrieve neither for the surgeons, but in these couple of cases, we are snaring and retrieving inside the foreguard catheter, and afterwards we implant an oversized devices with success. The fluoroscopic time and the procedure meantime was quite acceptable, but this figure is really awful. The amount of contrast, the mean amount for every patient was 15 cc per kilo. But I had to explain to you that the vast majority of the relevant amount of contrast administered in each patient had been accumulating in the first part of the learning course, and in the patient who had more complicated procedure included the two embolization patients. But now, in the last 4 years, I promise you that we were able to do with less of 2 cc per kilo in each patient, and moreover, we didn't find any kind of side effect in relationship with the administration of contrast. This is the first severe complication. This is a severe complication with severe stenosis of LPA for the obstruction of the right side and extrinsical compression of the lumen of this vessel. It was, I promise, more severe than it looks in this image, and we thought that if we should continue with this protocol. Okay. From my point of view, if something goes wrong, it's better to stop and reflect, don't disguise, and like anything is happening. Okay, if anything occurs, okay, don't pretend, don't disguise, and it's much better to abandon the gene, my friend, and don't continue with the same attitude. The stenosis was resolved spontaneously in these patients. We stopped the protocol during the next 6 months, and in this 6 months, by the growth of the vessel, the stenosis of LPA was completely released. For this reason, currently we accept that the moderate, even less than severe stenosis of the LPA provoking by the extrinsical compression of the right occlusal disc could be released in the coming month without problem. And this is the immediate follow-up, 3 exitus in the admission, during the admission, in the coming weeks after the procedure, but not in relationship with the percutaneous approach. It's sepsis and intestinal problems, and the mean and long-term follow-up. We have a mean follow-up almost 3 years. No evidence of vascular damage, but only clinical evidence, because we don't have analyzed all the patients by echo Doppler, and all of the 5 patients with stenosis from moderate to severe resolved in the coming 3 or 6 months without problem. In our center, the first positive effect to establish this kind of approach is that the neonatologists are less lazy to send the patient to the cath lab and don't prolong the medical treatment. Only 2 cycles, ibuprofen, and they are thinking about the possibility to send to the cath lab. But this is perhaps the most relevant application that we could offer you from our center and even from Spain. This is the comparison of the clinical benefit between the surgical approach and percutaneous approach. It was presented in the APC Congress in Milan by my co-worker Adolfo Sobrino. We established 2 groups in our own center, 20 per the percutaneous, 28 for the surgical, with the same characteristics, and the main target is to answer this question: is there any benefit over surgery? Because there is not a study comparing clinical benefit of percutaneous approach versus surgical approach. This is the same group. This is the statistical analysis, and we are really worried to obtain homogeneous group to establish with accuracy our conclusion. And both groups were really homogeneous regarding the postmenstrual gestational age and birth at the weight. And you can see in the table there is no different regarding the chronological age, and a slight more comorbidity before the procedure and after the birth in the surgical group. we applied this. This is the brilliant idea from my co-worker Alejandro Rodriguez, is apply this pulmonary score to establish the difference and benefits of these two therapies. The pulmonary score has been applying from the neonatologists from 2005, and this score is obtaining with this formula, taking into account these parameters: respiratory support, the oxygen concentration, and medication, but regarding only about corticoids and diuretics, because I have to remind you that this is the score to establish the pulmonary status, not cardiovascular status. For this reason, this score is not taking into consideration the hynotropic administration. We established weekly 4 days before and 4 days before and 4 weeks after the score, the pulmonary score, and you can see that in 2 groups, in surgical and percutaneous, there is no statistical difference regarding the pulmonary score. For this reason, we could establish that both groups were homogeneous. This is the conclusion. To simplify it, is that the percutaneous group had an earlier pulmonary recovery after intervention, and surgery group had a worsening after intervention and did not start recovery until 14 days after the procedure. For this reason, we could conclude that the pulmonary recovery seems to be early in percutaneous group when compared with surgical group. It's the first study using the pulmonary score to compare both techniques. We published in the pediatric cardiology, and we were lucky because Dr. Sobrino won the awards of EPC in Milan, but it was a great honor and a great pride, but also a great shame because you can see the pants that he was wearing, my young co-worker. This really in according with the Milan fashion style. Well, the problem is this handsome, really tall. If you look to me with this kind of pants, you think Dr. Zunzunegui is living in his car. But it's not the question. This is the second average group. In my opinion, this is a very risky group, and we have not been taken into consideration, especially when we are working with auto-expandable devices. In the vast majority of the cath lab, we permit that the young interventionists start with this, and I not agree, because this is, in my opinion, at least from my humble point of view, a very risky patient, especially if you are use AD1. AD1 have a very stiff delivery cable. Even the angulation in which the delivery cable should be adapted is really, really close when you are working in patients less than 8 kilos. For this reason, the tension that is transmitting from the delivery to the device is really, really relevant. And after on screen, this image for sure sounds to you familiar, this jumping effect perhaps toward the aortic lumen. This is one of the cases. This is 8 months, 6.5 kilos, and we close with 802 with a control angiography perfect before releasing from the aortic side, even with the left occlular disc quite included in the aortic ampulla. We decide to release the device. And what happened? Jump into the aortic lumen, creating a gradient with the diastolic extension by echo of 20 to 25 millimeters of mercury. You cannot be really, really happy with this result, and you have to try to release this stenosis. You can send the patient to the operating theater, but this is the maneuver when we are using in several patients. Put a very small profile balloon and inflate it. In some occasions, this kind of maneuvers works, and you are able to include the devices into the ductus. And in this way, you could release the stenosis and accommodate a quite nice forehand. You can see in the video the devices inside the ductus. In some occasion, when we can see the tension created for the delivery is so high and the curve is so close, we inflate the prior to unscrewing the devices, try to stop the damping effect and try to avoid the invasion of the left occluder disc into the aortic lumen. This works and it's really easy. We are using a Sterling balloon. I recommend deeply the use of this kind of balloon because it's passing through a 4 French interductor and the 10 millimeters is passing through the 5 French, and you can see that the damping effect is amortiguated for the balloon. And when you use 82, of course, the delivery cable is softer and the damping effect is not occurring, and this is one of the advantages when you are working with 82. 82 is a wonderful device, but not for ductors. I don't know. I love 802, but apply in so many places, but not in ductors. Because I don't know if you have the same experience, but when the left occluder disc is in contact with the ampulla, this configuration, like a bubble, is impossible to increase in the shape. And for this reason, it's really difficult to accommodate, and in some occasions, the left occluder disc could protrude inside the aortic lumen. But you can see this is really easy to adapt because it's soft device with this kind of balloon, in this particular case, 9 millimeters Sterling balloon, and with a good result. We have been doing about 6 patients, and it is work. And there are an incredible disadvantage if we compare the structure of 82 or 81. The microscrew is protruding in the 82, and it's really easy to snare, but in the 81 it's impossible because it's completely occult between the metallic necks of the devices. It's impossible to snare. This is an example of one of this complication. 5 kilos, we have to close the ductus and the ASD because it's a Down syndrome and try to avoid the progression of hypertension. We closed successfully with 81, but and afterwards we closed with a ASO occluder of 6 millimeters successfully, but after 1 day checking the result by echo, we recognize the gradient in the aortic lumen, and you can see, I don't know, an expected elevation of the pulmonary tension or anything like that provoked the migration of the devices into the aortic lumen. We try to do the same maneuver, try to include the device into the aortic ampulla, inflating a balloon inside the aorta. We try to snare simultaneously, but it was impossible because, as you can see, the snare was not able to catch the microscope because it's completely hidden and occurred by the metallic structure of the device. You can imagine this kind of devices could be snared by the body, but if you snare by the body, you need 4 or 5 French more in comparison of the seat with which you were doing the implant. And you have to pass through the doctors. You could imagine a seat passing through a doctors of 5 kilos patient. We are talking about 10 or 11 French seat. Okay, the 82, on the other hand, is really simple. Even when it was implanted completely, the protrusion of the left occluder disc indicate the withdrawal percutaneously these devices, and afterwards with the seat of 6 French we go to a snare, and we did really in a smooth way with a good result. For this reason, I think that we have to take into consideration this kind of patients, like risky patients, pay attention, and you should remember that the recommendation from the company and manufacturer is not indicated in patients less than 6 kilos and in some occasions less than 8 kilos. For this reason, although we are very sure of the skill we have been training, we can cause a disaster in these patients. Okay, we could really skilled. We can do some tricks like a magician because we are really expert, but you could create unexpected damage. Okay, be careful, please, with this average patient. And just a couple of slides about the adults and my experience regarding the percutaneous closure in adult patients is pretty humble and anecdotic, but we have been accumulating some patients helping to the adult categories to close. The first thing that I learned is to determine the shape and the size of the ductus in an adult is really complicated. For this reason, it's highly recommended to do a CT scan to establish in advance or use rotational angio to establish in advance in which kind of anatomical substrate we are going to work. And the second thing is the first slide of the adult part, is you have to establish with accuracy the QPQS, the pulmonary resistance. You have to do, in some occasion, in moderate adductors with prolonged outcome occlusion test. The occlusion test could be useful for two things. One, to establish what happened when the shunt is blocked, if with the hope of the pulmonary pressure is going to decrease, and afterwards, if you are just non-compliant bound, you could draw in any sense the shape of the data that you are going to face. And for this reason, in some occasions, we are using this kind of devices in 2 or 3 patients. Is the muscular occluder, because we need devices with bigger occluder digs in order to avoid the embolization to the aortic side, especially in patients with pulmonary hypertension. It's really, really common in South America. We have a lot of imported pathology, and we have to face 2 or 3 of these doctors, very uncommon in the Europe environment. Thank you very much.